Well, we have Ken Lucero, we have Dr. Robert Valdez, and we have Sally Cohen. And they will be talking about different aspects of health policy. And our moderator is Gina, and I never know how to pronounce it, Urias Sandoval. And I'll just hand it over to you on the table. I don't embarrass myself.
Good morning, everyone. Thanks for getting up so early and coming back for the second day of these sessions. I think you will not be disappointed. My name is Gina Urias Sandoval, and I work as a senior program manager for the Robert Wood Johnson Center for Health Policy at UNM. I'm humbled and honored to have the opportunity to introduce some of the people that I work with on a daily basis, who in my opinion are pretty remarkable, both in the work that they do, the things that they have researched and studied, and the influence and effect that they have on health and health policy in our communities. The first person I'm going to introduce is a woman who was recruited to the University of New Mexico College of Nursing at the Health Sciences Center to run a pretty extensive program in regards to health policy and nursing. She was recruited from Yale and was brought to the university, charged with serving as the director of the Robert Wood Johnson Foundation Collaborative for Health Policy and Nursing at the College of Nursing. She works very hard and is dedicated to the mission and vision of recruiting nurses at the PhD level who will someday serve and sit at national tables and influence health policy. In particular, her area of expertise is talking about health policy, not only in terms of the clinical work, which she has extensive experience and background in, but also in how it affects the policies that are put in place that help us improve our health and healthcare in our communities. It is my pleasure to introduce to someone who has a background in public health, American government, and who also is a splendid nurse and leader. She's a professor at the College of Nursing and the Executive Director of the Robert Wood Johnson Foundation Collaborative Program there. It's my pleasure to introduce Dr. Sally Cohen.
Thank you, Gina. I'm really honored to be here today. When I was invited, Emily mentioned it to me, I was honored, there's no other word that I can think of, to speak with you, not just before you today. When we talked about this panel and how we put it together, I knew that I'd be covering certain things, certain issues, and then it was really a good idea, thinking about the order that we're going in and the topics I want to cover. I'm glad to be the first one up, in a way. But my charge is also harder because I want to set the stage for what's to follow. So here we go. Let me just tell you briefly about this mouthful of words that I lead. It's the Robert Wood Johnson Foundation Nursing and Health Policy Collaborative at UNM. And I'll acknowledge my colleague, Dr. Drinda Welly, who's here, standing over there, and faculty with me. Now, we call it nursing and health policy as opposed to nursing health policy to clarify that we're not just looking at nursing policy, such as funding for nursing education, nursing research, how many nurses do we need. We're saying that we're looking at nursing and the whole array of health policy issues that nurses contribute to and can contribute to, and hopefully will make even more contributions to in the years ahead. So basically, the goal of our program is to prepare a new generation of doctorally prepared nurses. Those would be nurses who have a PhD. So all of our students already have a master's in nursing, prepared to meet our nation's healthcare policy challenges. The Robert Johnson Foundation has generously funded us, so the students who are going through the PhD program as nursing and health policy fellows have tuition, stipends, books, and many other benefits paid for. And we do have several Native American nurses in our group, and we're very proud of that. The collaborative's faculty and fellows engage in policy research to address the healthcare needs of America's most vulnerable populations, which certainly makes us relevant to the topics that we'll be talking about today. So without giving you, here's our website. I don't expect you to write it down. You can find me, you can find Gina, you can find Dorinda, all of us, and there's more on our website. As you can tell, I'm not the most technically savvy person, so I don't have bells and whistles and colors and all that. I'm just giving you basics, because that's how I like to think, and I tend to be a word person. So bear with me. Now, the objectives of my short talk today will be to talk a little bit about what is health policy and to describe the relationship between health policy and health outcomes. And to do that, I'll focus on the two areas that I know best in this whole array of issues, which are child health and nursing. My master's is in child health nursing. I worked as a pediatric nurse practitioner. And most of my scholarship since then has focused on aspects of child health policy, and of course nursing too. So what is health policy? So I'll give you here, the formal so-called, or one of the many formal definitions. And it really doesn't matter which definition you choose. They all boil down to pretty much the same thing, which is something like what you see here. These are decisions usually developed by public, meaning government policymakers, for determining present and future objectives pertaining to the healthcare system. I mean, it's pretty broad, and that's exactly right. We are not limiting ourselves to any level of government, any location of government, any type of government. But when we talk about health policy, traditionally it's been public. But I want to emphasize that as the years have gone by, going back, let me think now, I'm getting older, 15, 20 years as managed care came along, and as we look more and more at our healthcare system, it's also clear that health policy, I'm not calling it public health policy per se, but health policy must include private organizations, because we need to look at insurance, and insurers, private insurers, hospitals, some of which are private. We want to look at, there are many other types of facilities that are private, and there are, I'll even go further into say, there are faith-based institutions, there are child care settings, there are schools, anywhere where there are employers, anywhere where people are and people need health, there's health policy really is the broadest way that I like to think about it. So the integral components, and this is again the traditional type of stuff we see in textbooks, the people involved or the issues involved are legislation, meaning bills, laws, bills being proposals for laws, and laws once they are finally on public record and enacted, regulations, meaning what the government does to implement those laws, that would apply to, again, any level of government, federal, state, county, local, professional guidelines and standards and protocols, which get at that notion of private, national certification organizations for health professionals, joint commission that certifies hospitals, etc. Public health policy that looks more at public health, the health for the people, traditionally through state governments and tribal governments, of course, as well. And this definition I found had health advocacy, which I really like, because it makes it clear that the players are not just the people in the government, but all of the people who interact with government to help make, and private entities to try and make the best health policy we can. So given that, we know that the politics of health policy, if you just look at this list here and think of all the people I've talked about and all the people you know, we know that helps us explain why some of the politics are so contentious. Lots of interests at the table, as you know. So now to talk a little bit about outcomes research. I don't know, can you see this in the back? Yeah, great, thank you. Outcomes and population outcomes and outcomes research are related but slightly different. So let me just go forward to be a little bit easier. Okay, so let me do this slide first. In looking at the relationship between health policy and health outcomes, let's talk a little bit first about population outcomes, health outcomes. They're generally referring to the same idea. And they are influenced by many factors, most of which, interestingly enough, are beyond the reach of immediate healthcare delivery. So when we study increasingly, as we look at health outcomes, we know that social and economic factors affect the health of people, affect the population outcomes. So population outcomes are looking at groups of people, not you or I when we go to see a healthcare provider. That's our individual outcome. My weight, let's not talk about it, your issues, etc. But when we talk about population, we're aggregating people together. Health behaviors also affect health or population outcomes. Our habits, the advertising that we have that induces or encourages us to behave in certain ways, our motivation, our psyche, our depression, our mental health, our sense of control over our lives, all of which can affect our health behaviors and be affected by social and economic factors. And the environments where we live and work and play, if we can play. All of those things will affect our population outcomes. The air we breathe, the water we drink, the stress we deal with, the noise level that we have, the bombardment from computers and other things coming at us. Those are all part of the environment that will affect the population outcomes. And I put down here the structure of healthcare, meaning the healthcare delivery systems. Are there structures in place for people to get care? And when there are structures in place, are they open? Are they amenable? Are they culturally sensitive? Do they have people who understand language and culture? Do they have providers who are understanding? Do they have people who understand the communities where they work? Those are parts of the structure of healthcare. So going back to this, if we look more carefully at the box here of healthcare outcomes, we're looking at the end results that include, but these are not limited to, the effects that people experience and care about, such as changes in their ability to function. That would mean, do they have disabilities? Are they impaired in some way? Are they sick? Do they feel weak? That would come under the category of morbidity that I'll talk about in a minute. And certainly for chronic conditions, what's their people's quality of life? Those are also part of outcomes that we look at. And the black or white one is mortality. Are they alive or dead? How many years do they live? Those are considered health outcomes, and I'll give you some examples of that shortly. So by linking the care that people get to the outcomes that they experience, outcomes research has become the key to developing better ways to monitor and improve the quality of care, and I will add the quality of life. So we're not just looking at, did you get the care? We want to make sure that you've got a care that will affect in the aggregate way people's life. Are they living? Are they living longer? How long are they living? Are they healthy? Are they weak? Are they impaired? Are they disabled? And what's the quality of their life? Are they able to do daily functions of life? Are they able to work? Or does their illness keep them away from work? And this is from another agency, ARC, the Agency for Healthcare Research and Quality. And I'm not going to go into all of that. So here's the list again. So talking a little bit more about health outcomes, I'm repeating that it's at the population level. We're also looking at, when we measure it, changes over time due to an intervention. If I educate you, or a group of you, about a certain condition, and I do it at time 1, and I measure it later at time 2, are more of you healthier? Are more of you, has your blood pressure gone down? Has your blood sugar gone down? Has it gone up? Are you able to work more? What do you think, in your experience, is your quality of life? Those are the outcomes that are measured after an intervention. Are you feeling ill? Morbidity, that's the fancy word. Mortality, length of life, again, as I said before. What's your quality of life? And outcomes need to be measurable. That's the big push for them. We can't just say what it is. We want to be able to measure it across time and between populations. So here are some examples to bring it home again. We've got mortality, and an example of that is infant mortality. Infants referred to babies under 1 year of age. Okay, under 1 year of age, you're an infant. Physiological measures such as blood pressure, weight, hemoglobin A1C or blood sugar. A clinical event, did you have a stroke? Do you fall? Do people fall more or less as a result of an intervention? And patient satisfaction. How do people themselves feel about their care? And this is often measured through consumer assessments, some of which are done on a large scale with many thousands, hundreds of thousands of measures done by the federal government. So, now let me focus on one of my two areas, which is nursing. And without going into numbers and everything, just give you the concepts. As many of you know, or if you don't know, I'll tell you, traditionally, the entryway into licensure as a registered nurse, there are many different ways. Here in New Mexico, most of the nurses are licensed through the education as for associate degree at community college. But there's also baccalaureate entry, there's master's entry, many ways. So people started to look at the relationship between the ratios, how many patients on a unit a nurse had to carry, and population outcomes, in this case mortality. And they found that the fewer nurses, the fewer patients in a nurse's caseload every shift, the better off the patients were. And that might seem intuitive to you. They adjusted for all kinds of things. Why is it important? Because in many hospitals, when they go to cut the budgets, the first thing they cut are the nurses. And at bad employment, the first group to go are the nurses. And if we can document that by having more nurses or a better patient-to-nurse ratio, you'll have better patient outcomes, which we were able to do. That makes a difference in the policies of hospitals and their willingness to hire nurses at a certain, i.e., at a certain rate. We can also look at the education level, which is the same thing. We're going to say to ourselves, if the nurses in those hospitals have baccalaureate degrees, if more of them have baccalaureate degrees compared to associate degree, the patients will do better, and they do. And we can also see nurse practitioners in primary care settings, and research has shown that when you compare care by nurse practitioners to physicians, often the care is the same, the outcomes are the same, the hemoglobin, the blood pressure is the same, and sometimes in some ways, especially patient satisfaction with regard to communication, is even better. Some of this evidence has led to the Institute of Medicine's now infamous report among nursing on the future of nursing, which is all done in conjunction with the IOM and the Robert Johnson Foundation. The reason I mention it here is it's called all evidence-based. It's based on evidence and population outcomes. And here in New Mexico, we've implemented these recommendations through a consortium of all the nursing schools in the state to push for the baccalaureate degree. There only are about 2 or 3 baccalaureate programs in all of New Mexico. So we now have a plan with state government support to try and integrate the curricula so that associate degree programs will be offering in collaboration with UNM and NMSU baccalaureate degrees. So I'll quickly, because I know my time is up, but I don't have many more slides, tell you the same measures apply when we think about children. If we think about children with special health care needs, who are transitioning to adulthood and have special needs, they're not quite pediatrics, they're not quite adults yet. We know that they need coverage, which they often lose because of Medicaid or other eligibility, as a way to reduce morbidity, less illness, and I did this backwards. Increase the risk and improve quality. We also know that when you expand children's coverage, which is why we've had many pushes for that at the federal government level, we have fewer visits to the emergency department, improved child development, and improved immunization rates. And the one I'm going to go to the last is my favorite one, which is by Glenn Flores. His research looks at children of minority populations, especially, not only Hispanics. He looks across the board at how to narrow the disparities between minorities and children and other population. And his research shows quite clearly, and some of it's with Native Americans and looking at breastfeeding rates, that the only way to improve outcomes is to have community collaboration, meaning people from the community working with the providers, healthcare provider education, healthcare systems modification, meaning that the researchers and people from the staff are from the same community as the patients. Now you might say to me, what's new there? Don't we already know that? And I would say to you intuitively, yes. But what makes this different and what people want is that it shows that by doing this, you'd have an outcome change in the population at hand. And that's why much in the healthcare reform legislation had provisions for community workers, had also provisions for nurse practitioners, had research on a little bit on coverage and kids, and had, what I didn't go over here, the medical home, because research has shown that, especially for pediatrics, the area I know the best, which was the first place that the medical home concept was introduced, the concept of people having one place to go for their care. We can show that the medical home makes a difference in the outcomes of children. So the last slide I want to tell you, just leave you with, is this, which is that policies can affect outcomes of populations, and population outcomes can in turn affect policies. Because if we see poor outcomes, we'll try to improve them through certain policies, and if we see outcomes that have been improved through certain interventions, we'll try to include them in policies. Also, we learned from our work the importance of engagement and participation of communities. We really can't improve population outcomes without working with the communities at stake. We know that we're looking at not just public, meaning government, but organizations, private organizations, public-private partnerships, a mix of private and public. And we know that after all our research is done, and we have some outcomes to talk about, the next step is how we disseminate our policies to practice and to public communities that don't just include government, but include everybody, lay communities, people in this room, and everybody that you know. So I hope in this short time, I've not confused you, I have not bored you, but I've set the stage for what's to follow here with my colleagues on the panel, and also for what hope for you will be the rest of a wonderful day. Thank you.
Thank you, Sally. The next speaker that I'd like to introduce is a person who was recruited to the University of New Mexico over 4 years ago. When the Robert Wood Johnson Foundation approached the University of New Mexico for a partnership in creating a Center for Health Policy, they couldn't have picked a better person to serve as executive director. This person not only serves as executive director for our center, but brings with him his experiences across the nation in working on health and health policy. Dr. Robert Valdes not only serves as our center executive director, but he's also a professor at the Family and Community Medicine Department at the Health Sciences Center, and holds a faculty position within the Department of Economics at main campus. He is dedicated to our vision and mission of recruiting Hispanics and Native American PhD students, supporting them both financially and providing them exposure to health policy opportunities, both locally and nationally. He sits on a variety of boards, both regionally and at the national level. He takes with him the information that he gathers both through our doctoral students, our faculty and senior fellows, and the work that we do here, the work that we're doing today, with him to the Hill to discuss these issues and represent our community. This person not only works carefully at helping all of us understand what health policy is and in our training of the PhD students, but he's also someone who truly cares about our communities. He cares about this community and communities across the country. I am humbled and honored to introduce to you my boss, Dr. Robert Valdes.
Thank Thank you, Gina, for such a nice introduction. You can keep your job. I thank you all very much for allowing me to speak with you this morning and just to share a few thoughts about health policy. I'd like to start a little bit with a story of my own introduction into health policy that occurred when I was a professor at UCLA. Back in the early 1980s, the city of Los Angeles sanitation department wanted to create an incinerator, a garbage waste incinerator project. And they were going to put 3 incinerators in 3 different sites around Los Angeles County. So they looked at a variety of locations. They looked at a variety of places. And where did they decide they were going to put those incinerators, or at least the first one? Yeah, you guessed it. They were going to put it in a low-income, high minority dense community in central Los Angeles. Well, of course, the EPA, the Environmental Protection Agency, and others required that an environmental impact assessment be done before the project could move forward. And so the county commission and the department contracted with a health impact assessment firm made up of epidemiologists and other kinds of scientists who focused on looking at the effects and environmental impacts that various projects have. Very highly technical health impact assessments. Very complicated mathematical models looking at how exposure to a variety of conditions leads to cancer. And those mathematical conditions are something called a one-hit model. That is, they take the chance that someone in a distant location within that site area may have been exposed to something that's carcinogenic. Well, long story short, the company came up and made a public presentation about their model and their problems, or what the issues were with regard to the incinerator. And they gathered people from around the community, and they said, not to worry. This incinerator is as safe as eating a peanut butter jelly sandwich. Well, what did that mean? For most of us, particularly in my community, we don't even eat peanut butter. We don't like peanut butter. So, peanut butter sandwiches didn't mean a whole lot to us. And, from a technical standpoint, it was pretty straightforward. Peanut butter causes, bad peanut butter has aflatoxins, which can cause serious medical conditions. But they're pretty rare. It's pretty rare. The community was up in arms. The community was upset. They weren't included in these discussions. They weren't asked what the issues were. They weren't asked about whether they even wanted an incinerator project. So the city council got involved and said, we better get some community representatives on this health assessment program. So they asked a couple of people, including myself, to come over and take a look at what was going on and give some impressions. First thing we did was, of course, try to figure out what was it that this project was supposed to be doing. So obviously they wanted to reduce the amount of landfill that was being used. And of course, we asked, why did you choose this site for the first incinerator? And it was real clear that they didn't want to put the site in the really ritzy part of the community, where they had actually a nice location where they could have done it. They didn't want to put it in the other locations either. So the least powerful communities, of course, got the nod. They got to have the incinerator. But as we went out to find out what it was that people wanted, what they were concerned about, we discovered it wasn't about cancer. It wasn't even about the incinerator project per se, about incinerating garbage. It was about the fact that This site was going to be located in a densely populated community with lots of children who played outdoors on the streets, who already were suffering from air pollution and from high rates of asthma. And what did our community see? Well, they saw a huge amount of traffic volume that was going to be brought into the community that threatened their children, and that the increased air pollution, or potential air pollution, because that's presumably these were the high-tech incinerators that weren't going to pollute anything, might add to the asthma problem that the community already wanted to have dealt with. Well, once that came out, we had to restructure and get this organization to restructure its health assessment, because the typical health assessment, which was very technical and looked at cancer and death, didn't bother to look at these closer in kinds of mid-course health outcomes. Potential for accidents, potential for increased asthma severity and problems. And so restructuring that whole health assessment was an eye-opener for not only the health assessment organization, but for the EPA and for others. And as a result, that incinerator wasn't built in that location. So what's the moral of this story? I think the moral of this story is really the three principles of health policy that I've been operating under most of my career. And I want to share those with you today because I think they help link the discussion that we had yesterday as people introduce themselves and the issues around health boards and health assessments or needs assessments or health impact assessments. Those words get moved around a lot, get changed a lot, but they're pretty much the same thing. The first principle is really that all health policy is local. The federal and the state health policy that takes place is primarily about finances, particularly at the federal level. It's about finances. But county, state, local, and tribal communities are really where the action is. Why? Because people are there. Because leaders have to live in those communities and also have to live under the health policies that they make or don't make. The second principle is that health policy is always at play. What do I mean by that? I mean that, we were talking about government being primarily the source of health policy, and meaning the health leaders, or the leaders at the time, whether it's the governor, the lieutenant governors, the councils, whether it's the city council, the mayor, whoever it happens to be, the county supervisor. Oftentimes they don't have a particular health policy agenda. But what does that mean? Does that mean there's no health policy in place? No. Even if they don't take an active role in defining a health policy agenda, it means there's a health policy agenda already in place. So what's in place, the status quo, in fact becomes the de facto policy of that administration. So communities have an opportunity to address that status quo, to move it, to direct it, and to get the attention of leadership to address those issues. And that brings me to the third principle of health policy, and that is people in a community know what needs to be done to make their communities healthier. I was reminded of a story recently of a tragic story, really, of a woman in Northern California. I was watching a news report about this over the Easter season. A woman who was coming home from work late one day, taking public transportation. She took the BART, the train that takes her into the city. She was going home. She was parked in one of those remote parking areas where you then take the little shuttle over and you catch the train. She was arriving home late one night, and she was abducted, and then later raped, and then later murdered. And when I saw the news report, I was reminded by the newscasters that it was her fault. How could it be her fault? They were telling us individual ways of how to be safe. Here's the rules about how you should be safe. Why was it her fault? It was really about an issue of dim lighting. It was about the social and economic circumstances in which she lived and the commute that she had to take. And all of these issues really underscored the very nature in which we often take health and safety issues as individual and individual responsibility issues, or they get reported that way, or they get thought of that way. When in fact, they often are reflections of social ills and really the social responsibility to make our communities safer for people to engage in healthy activities, whether it's play or whether it's work or whether it's transportation. Well, many communities around the world actually have taken this challenge on. There's a movement that started in the 1980s called the Healthy Communities Movement. There are healthy communities in the United States, and there are healthy communities all around the world. And this is really an outgrowth of efforts by local community members, like the one I described in Los Angeles, who are looking for environmental justice. And out of this environmental justice effort, they created and often engage in something I call public epidemiology. People aren't epidemiologists, they're in the trained epidemiology sense, but they know when their water's not well. They know when the air's been polluted. They know when traffic has gotten out of hand. They know when the medical care services they're receiving or not receiving are adequate or not. And many of these environmental justice cases, in fact, in community epidemiology cases, have found their way into environmental justice efforts around the country. For example, there was a court case in Lowell, Massachusetts, where one of the rivers had been polluted for some time by manufacturing. There was a large number of birth defects that were resulting in a downstream community. And epidemiologists from the state kept coming at the request of local officials and others to test the water and to test the air and to test other potential sources of contamination. And of course, the official results were that, well, there just wasn't enough contamination to really be the cause of any of these problems. And yet the community knew that there was something going on. So what did they do? They actually organized a coalition. They gained the technical expertise from others in other parts of the community, in their community, who had the technical expertise to actually do their own testing. They then engaged in that process of taking this sort of expert versus expert efforts, and we actually have a place in which that kind of arena exists for us to take our health policy concerns. And we often don't use it because we think of health policy as something that's done by the legislature or executive branches of our governments or governments. But there are also courts. The court system allows us to bring that sort of expert by expert efforts together. The community organizations, the community coalitions, in fact, brought their experts to bear against the official experts. And in many of these environmental justice cases over the last 10 to 15 years have won. And many of them, or several of them, have been in Indian country, for example, in Washington and Oregon and elsewhere. Let me just spend what few minutes I have left talking a little bit about health impact assessments and link this health board and health needs assessment discussion together. I want to tell you a little bit about a program called PATH, People Assessing Their Health Project. It was a project that was done in 3 communities in eastern Nova Scotia. They're communities not unlike communities in New Mexico. That is, they're geographically isolated, and they often face very difficult socioeconomic circumstances. Now, what they've done is create health impact assessments that, first of all, examine a broad range of factors and not just focused on health care per se, as what the issue is with regard to whether or not their communities are healthy. So like yesterday, we talked about a whole variety of issues that are social, political, and economic in nature that actually, in fact, are the root causes of the health and healthcare concerns in our communities. They use these health assessments as a way of identifying what community members consider are most important. These health impact assessments and the process of putting them in place encouraged all members of a community to be part of the decision-making process and the health policy-making process. And it's in this participatory process that, in fact, we create community, and by creating community, we enhance the health of our communities. By using this participatory approach, they also more adequately reflected community concerns and priorities. And lastly, once they sort of did this process, they were able to provide useful information to the community health boards and community leaders to actually take action to resolve those problems. Now that sounds pretty nice, right? But it actually is pretty easy, because most health assessments are often talked about as if they're really highly technical, like the one I talked about with regard to the cancer hit model that was used with the incinerator project. But low-tech approaches, talking approaches, community participatory approaches can in fact have huge impacts. And it's really quite simple. Many of you know the process already. Get a meeting, get people involved. Second, try to have a group of facilitators who reach out to each of the community members and hold broad discussions about what the conditions are and concerns they have. And in that process, in fact, you're doing data collection. Oftentimes people think about data collection as something that you just look at numbers. But getting people's concerns and ideas, consolidating them, is data collection. Third part of the process is really having that steering committee pull those data together in a workable way. And the fourth, of course, is then having that group, whether it's the health board or whether it's the steering committee or it's the coalition leadership, work with local leaders to see that the assessments, in fact, are used in the decision-making process. Now, this highly participatory process really helps people shift their thinking from this notion of illness or problems at the individual level that I described a little bit with the story about the lady and the transportation issue and her subsequent death, unfortunately, to really thinking about the social ills and the social issues that need to be addressed. It allows us to consider how programs and policies can either support or weaken community health. In all three of the communities in Nova Scotia, this process also did another thing, something that's extraordinarily important for the resilience of our communities, and that is to bring to light the actual capacity our community has and the control that we have to improve the conditions that allow us to create a healthier community. PATH, that program I just described from Nova Scotia, illustrates how ordinary residents can be at the very heart of health policy decision making. And that's what we're really talking about in this session, these sessions today, yesterday and today, and also what this follow-on work will be about as we work to try to help and support your efforts in your local communities to create healthier communities. Thanks very much.
Thank you, Dr. Valdes. The third and final speaker for this morning's session is a person who, so let me just start by saying, early on, the Robert Wood Johnson Center for Health Policy, Dr. Valdes recognized that in order to understand health and health policy, and in turn train our health policy leaders, these PhD students that we support, both financially and otherwise, that we had to understand the health and healthcare needs of each community within our state. To have a true representation at the national level would mean to have a true understanding of what the needs and concerns were of the communities, and in turn, helping to provide programs and research and other things that help us to improve that health and healthcare and provide information to leaders at the national level to make changes in policies that help our communities. He recognized that there was importance of having someone who could work directly with tribal communities on the issues of tribal community health policies. Dr. Valdes chose Ken Lucero to be that person. Ken Lucero is a person who not only cares about the community that he comes from and has extensive knowledge and work within his own community, but across the state, other tribal communities, and even within our own, even urban communities. Ken Lucero sits on a variety of committees and boards throughout the state and also at the national level. He takes with him the information that he has collected from you, the information and work that he does at the center, and carries that with him in his backpack when he hikes up the hill to Washington to represent our state and our communities. I'm honored and pleased to introduce Ken Lucero this morning, and I did want to also say one more thing. We are in this room today because of the thinking and coming together of two people in this room. One is Dr. Emily Houses, who's a professor at the College of Nursing and the Health Sciences Center, and you've heard a lot from her today. She's a researcher and primarily focuses her research on tribal communities. She is dedicated to improving the health and health care of all communities across this country, but has a primary interest in the tribal communities. She and Ken Lucero got together one day and talked about what it would mean to bring all of you together for a 2-day meeting, to really talk about the importance of a needs assessment, hear from you what the needs were in your community, and to take that on to a second step. They had to find money to do that, so they put their brains together, they wrote something really pretty. We helped them submit that to the National Institutes of Health, and the Health Disparities Group through the National Institutes of Health funded this project today. So just because of these two that we're here, I am pleased and honored to introduce one of the two. He is an esteemed colleague of yours and an esteemed colleague of mine, Mr. Ken Lucero.
Good morning, everyone. Good to see all of you here today. I know you guys are kind of far back in the distance, but I think you'll be able to hear me. It'll make sense to you after we get through with the panel, because we're actually going to break this room into half, so that's kind of why the tables are divided the way they are. So it's not that we want you to stay back so far. We just for convenience sake, when we break into the next session. But I do want to thank you all again for coming and for attending the sessions today and yesterday. I think that it'll be a productive day that we have also in front of us. Yesterday I think was pretty good in terms of talking about what the needs are. I think a lot of us had a lot of the same hopes and frustrations about working in our tribal communities and kind of what the challenges are that we have. So hopefully we'll be able to help each other to move forward in our communities to create better and healthier communities. But today, or this morning, what we really want to talk about is health policy. And for my portion of the panel, what I'm really talking about is kind of the health policy, the federal government health policy that has been pretty much put on and created for us. So I think as many of us know that since the creation of the United States Constitution, the relationship between the tribes and the federal government has gone from treaty making to assimilation to reorganization, termination, self-determination, and consultation. And as Mark Trahan alluded to yesterday, he feels that then the next phase is leading into contraction, meaning that the government's downsizing, and there's just going to really be a lot less resources available to us as tribes, who even at this point are always battling over the barest of bones that they make available to us in terms of federal funding for our programs. So the roller coaster ride that describes the federal trust-tribal relationship has led to an overly complex and contradictory set of rules and regulations. These rules and regulations often limit a tribe's ability to focus on developing its own policies and managing itself for the benefit of its people. Throughout most of our history with the United States, the tribes have been treated as children or wards, needing the guardianship of the United States. And in quite a few instances, this is true, and as the tribes did require protection from the individuals and other government entities. Unfortunately, there are probably just as many instances where the tribes have needed protection from the federal government itself. So some of the trust relationships and the obligations that exist today include the provision of education, healthcare, housing, and social services. Land, water, and mineral rights are also a part of the federal-tribal trust relationship. So in order to administer these relationships, the federal government has established numerous agencies that deal directly with the tribes and tribal organizations. The Bureau of Indian Affairs, Bureau of Indian Education, and the Indian Health Service are examples of these agencies. These agencies use constitutional or congressional legislation, Supreme Court decisions, and executive orders to guide their interactions with the tribes. The agencies and the tribes use these tools to create and redefine services for Indian people. So what is the true impact of the federal policies for tribal people? Many of you will notice this slide if you were fortunate enough to attend the federal convocation that we had recently. It was a great gathering, but unfortunately we talked about a lot of the same situations in terms that we just don't seem to be getting what we were promised from the federal government. You'll see here from the slides that the result of the federal policies to date has really been really laid out really nicely from a report that was issued called The Quiet Crisis: Federal Funding and Unmet Needs in Indian Country. And you see in the slide, 318% were 318% more likely to die from diabetes than any other population in the country. We're 630% more likely to die from alcoholism, and we're 650% more likely to die from tuberculosis. Now in the country, most people don't even get tuberculosis, much less die from tuberculosis. This is really a tragedy for the healthcare system and for our communities and for our people for that was to even happen to us. More close to home, in New Mexico, the New Mexico Department of Health in 2008 issued the American Indian Health Disparities Report Card. And you'll see of all these different disparities that they lay out here, that deaths related to alcohol and deaths due to diabetes, homicide, and late or prenatal care, and motor vehicle deaths, you'll see that they have asterisks next to them. And what those asterisks indicate is that Native Americans, American Indians, are twice as likely to die from these conditions than the next closest race. So if Hispanic Americans had the next highest rate of motor vehicle deaths, Native Americans were twice as likely to die from that same incident than they are. And so we've got really just out of control rates of different health disparities that are going on within our communities. So how did we get here? How did we get to a place to where it seems that all of our health disparities and the way that we die as a race seems to be just disproportionate to the other races in the United States. And I think we have a pretty good idea about what happened to us. We have lost control of our health. It has been taken away from us and turned upside down. Instead of approaching health as we have done for hundreds of years, we approach medicine from a disease burden model. And instead of looking at ourselves holistically, we are divided up into agencies and departments, and our health is directed by regulation and legislation. But this is a difficult decision for us. By treaty, land grant, Supreme Court decisions, and executive orders, the federal government has committed to the provision of health care for Native Americans. This is in exchange for the thousands of acres of land and other things that have been taken from Indian people across the country. So we have policies developed for us that have then had a detrimental impact on our health. In regards to treaties, in November of 1991, Senator Daniel K. Entryway, who was chairman of the Senate Committee on Indian Affairs, said this about treaties. He said, of the 800 treaties, the record will show that the United States Senate just ignored 430 of them. However, we called upon the Indian nations to live up to their promises in the treaties. The U.S. Senate did ratify 370 of them, and of the 370 of treaties that this Senate, our predecessors, ratified, the United States violated provisions in every single one of them. The other significant pieces of impact that have created the federal trust relationship with our communities has been the U.S. Constitution. And really this is where we get the basic, the historical foundation of our relationship with the federal government. In the U.S. Constitution, there are two clauses that creates that relationship. First, the Commerce Clause, which is Article 1, Section 8, Clause 3, states and it authorizes Congress to regulate commerce with foreign nations and among the several states and with Indian tribes. The second one, the Treaty Clause, Article 2, Section 2, Clause 2, granted the authority to Congress and to the federal government to the exclusive authority to make treaties on behalf of the United States. Sometime later in the 1800s, the Senate, because it was not, or actually the House of Representatives, because they didn't have a hand in creating treaties or saying what was going into treaties, actually created a law that prohibited treaties from being made anymore. So it was in 1879, in fact, that treaties were stopped between Native American tribes and the federal government. So two important things that were created because of this, these two clauses was the government-to-government relationship that you'll hear a lot of tribal people talk about, particularly tribal leaders, always talking about the government-to-government relationship. This is where they get the basis of that relationship from. It's based in the U.S. Constitution. And the second is trust responsibility. The trust responsibility, the commitment by the federal government that they will have protection, provide protection to tribes and have a certain relationship with those tribes, created that trust responsibility for those tribes. One thing, another concept that actually usually gets thrown in this mix is the idea of sovereignty. And I think it was great that we had Mr. Trahant here yesterday, because as we talked about yesterday, he was the person that put President Bush on the spot about sovereignty and about what that means. And one of the things that President Bush says in that speech, or in his response, is that the United States gave sovereignty to the tribes. And that couldn't be any more wrong of a statement for a president to make, because tribes were not given sovereignty. Sovereignty, Native American sovereignty, is the inherent right of American Indians and Native Americans to exist as a separate people with their own values, norms, and traditions. And so these values, norms, and traditions existed prior to the establishment of the United States and Native American. Sovereignty is derived from the fact that Native Americans were here on this land called the North American continent prior to first contact with the Western European civilization. So again, it's not something that's been given to the tribes, it is something that will exist for time immemorial. But however, due to the federal tribal trust relationship, the degree of complete tribal sovereignty is constantly changing. Some of the other federal policies that have had an impact on our health policy has been Supreme Court decisions, and that really impacted the relationship that we have as tribes to the nation. Most notable is something that's called the Marshall Trilogy. And the Marshall Trilogy Supreme Court cases happened during the time of course, Supreme Court Justice John Marshall. In 3 cases, Johnson versus McIntosh, the Cherokee Nation versus Georgia, and Worcester versus Georgia, set the tone for much of the federal government interactions with the tribes. These cases had implications in the area of land ownership, federal jurisdiction, and the overall trust relationship. In the Johnson versus McIntosh case, this case considered the question of who had the right to sell and acquire lands. The Supreme Court decision, in part of their decision, they stated that the doctrine of discovery was used for the defendant to find in favor of McIntosh. And the doctrine gives legal right to the United States as discoverers of the land to occupy the land. So in his opinion, Justice Marshall stated that the Indians, that their power to dispose of the soil at their own will, to whomever they pleased, was denied by the original fundamental principle that discovery gave exclusive title to those who made it. Basically saying that because the Americans discovered the United States or discovered the North American continent and discovered the Indians on them, that they had the right, they were the only ones that had the right to sell the land, being the United States. And that ultimately meant that the Indian people could not occupy them, they could occupy the lands, but they did not have the right to sell those lands to anyone but the federal government. And this thus established Indian title, which later was used to establish reservations and was also used to create the programs that we have, such as the Indian Health Service. Cherokee versus Georgia, this case was really a question about the state-federal tribal relationship, and it was in many ways a good thing for tribes, but at the same time was not such a good thing for tribes. It was good for the tribes in the fact that it ruled that the state of Georgia did not have any authority over the Cherokee Nation. They didn't have any rights to impose laws over them. And that, but on the other hand, the ruling also stated that tribes were not really foreign nations, as it was stated in the Constitution, but they were instead domestic dependent nations. And the tribes were also referred to as wards of the United States and in a state of pupillage, which established then the initial federal tribal trust relationship. So at that point, during that court decision, it really put the tribes at a lesser level than, say, we would want to enjoy even today. We're always trying to say we have that federal government-to-government relationship. But this Supreme Court decision really kind of put us again as a ward and as something that had to be cared for and not really seen as equals in the eyes of the Supreme Court. Finally, in the last court case, Worcester versus Georgia, it was another issue in that Georgia was trying to make rules and decisions impacting Cherokee lands. The Supreme Court said that they did not have any jurisdiction over the lands, and so they were told to disregard it. The person was trying to live on Cherokee lands, but then the state of Georgia wanted to assess him a fee for living there. So this 20 minutes went by really fast. I guess I could talk all day about this. So really what I need to get to and really talk about is about the kind of the health policy, the legislation that really formed the healthcare system that we know today. And that's really the Snyder Act of 1921, the Indian Self-Determination Act of 1975, and the Indian Healthcare Improvement Act of 1976, which now is, of course, the Indian Healthcare Improvement Act of 2010, as it was attached to the Affordable Care Act. But really, those are the three primary legislation that created the relationship between the tribes in regards to health and the federal government. And of course, the Indian Health Service is the primary So the Indian Health Service is the primary deliverer of the federal responsibility for that. The 57.6% that we see here really shows the number of people who are eligible, Indian eligible people, who actually access the Indian Health Service. So there's about 3.3 million Native Americans that are eligible to receive services, but only about 1.9 million of them actually receive service from the Indian Health Service. Some of the other federal policies that have had impact on our health have been the Commodities Food Program. And that Commodities Food Program has really been, I think, a detriment to a lot of our people in terms of their health. And in the respect that the food that was often given to them, given to our people, contained a lot of fat, a lot of sugar, and even, I hate to say it, fry bread, which we all, many times really cherish and love to eat, isn't really the healthiest food for us. And I think it is, one, a symbol of resiliency and sustainability for Indian people, because it was actually originally created during the Long Walk of the Navajo people. They were given lard, flour, and water, basically, to sustain themselves so they wouldn't starve, and they created fry bread out of that. But again, is it really the healthiest food for us to be living on and to consider the traditional rye bread? And so we kind of start getting now into segueing into talking about tribal health policy. And really, what is tribal health policy? And is rye bread really something that we see as a part of our core? This slide here really talks about the healthcare system. We talked about earlier about how the way that we practice medicine in our homes, even still today, and how we did it back then is really a lot different from the way that the Western model and the way that our health programs that are delivered to us from the federal government. Native Americans look at things in a holistic, spiritual, and a balanced way. We promote health, trying to be active, eating healthy foods that we grow from our gardens. And really the overall goal and concern is about the community's health. And we all have concern for each other within our community and in the larger Indian community. And we value family and community participation. Whereas in the Western society, the model is allopathic, the medicine is physical, the health is really about a disease burden model in that you almost wait until you're sick and then you treat your conditions. So the focus is really on treating the disease, and the goal is to cure and control individual disease. And then one of the other things is really about the confidentiality. When we talk about behavioral health or other problems in our communities, a lot of times it's the family that gets involved and really shares in the improvement of health for that individual. Whereas in the Western world, it's all about confidentiality and making sure that no one sees that you're accessing those services or that you're parked there at the substance abuse center and those kind of things. And so it creates this aura of that you have to hide your condition, that you can't turn to anybody for help. And so I think in a lot of ways it's not healthy for us, and it's something that I think is something that we can probably change. So really what I want, my final point here is that with all the federal health policies, state policies, and policies in general that surround us, that we really need to start looking at what the strengths are within our own communities and within ourselves, and what we find is our core values, and that we need to use those core values as kind of a filter for all of these policies that have been imposed on us over the years, and really look at what's in place with us in our communities. And the way that we can do that is by the utilization or the creation of a community health needs assessments. We have that ability to incorporate our core values into those assessments and have the results come out, something that how do we get more towards a tribally sense of community and more related to those core values, and really filter them again through those core values and really come out to create what we would call tribal health policy, something that's more close to your cultural traditions, your customs, and your way of life. Thank you.
Thank you, Mr. Lucero. At this time, we'd like to open the floor up for a question and answer period. So if you have a question, raise your hand and I'll try to walk over to you with the mic.
Thank you for your presentations. I'd like to recommend that the schools also focus on community coordinated in-home care. In northern New Mexico, I think all of our communities are focusing on keeping our people at home versus sending them off to nursing homes. And the 8 Northern Indian Pueblos had a demonstration project back in the early 80s on this activity, and from Tisuki to Taos. And we proved to the state that community coordinated in-home care does work. However, that program is not an Indian country. And I'd like to see that reinitiated within Indian country. Or northern New Mexico. Just say northern New Mexico. On the policies, I also like to see more work on the impacts of GE, genetic engineered and genetic modified foods on our health impacts to our communities. We've never had miscarriages within our communities. Now we do. And I attribute that to the current food systems that we have in the United States. I'm happy to hear about the Environmental Protection Agency's ways of doing community assessments. I'd like to see a change in that too, if the school can help the country with that change, where right now the control is a white male, 6 foot, 185 pounds, da 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 da. I'm not that type of a person. And so we need to have models that reflect more of our communities versus some Eastern model. And I'd like to thank Ken for showing the connections. In Indian country, it's all about connections. We're related to everything around us. And when we come to the Western way of thinking and schooling, it's all about disconnect, and it's about separations, and it's about putting up walls. And thank you for bringing down those walls and showing that we do all fall under the core values, and that's how we kind of run our communities. Thanks, Ken.
Yep.
Good morning. This is for Dr. Cohen. A lot of our Indian nurses in IHS have associate degree for nursing. What determinations did you use to indicate that bachelor BA nurses give better care than associate degree nurses?
I can, well,
Yeah.
it's on? Okay, so I can use this mic. You know, it's interesting you asked that question because in preparation for this, I reviewed the articles that were published that I made. There was Linda Aiken's work at a university in the East, and she did national studies and state studies, and she did even some international studies. And often those same articles are quoted over and over. And then I read some more recent ones that could not show as strong an association. So I'm glad you asked that question, because I was going to volunteer and say that one has to be careful that not all the evidence is great, is excellent quality evidence, and that we all make mistakes of, and policymakers of assuming that whatever that evidence is valid. So it's done by, the evidence comes from several studies done mostly in the early 2000s, which showed this correlation. That said, let me go back and say I saw one or two recently that just said they could not reach that conclusion. And we all, including myself, have worked in a team model where with mostly associate degree nurses, and that's the argument here in the state. We still can provide very good nursing care without having it. I think that, just to embellish on it, the thinking is that as the healthcare system becomes more complicated, and as healthcare reform, not just meaning the law, but everything that is wrapped up in healthcare reform comes along. And when you look at the outcome measures that the government's requiring of many hospitals, they are nursing dependent measures. And that will affect reimbursement, at least for Medicare payments. You're looking at falls, you're looking at urinary tract infections, that come from indwelling catheters, and bed sores. Those three by themselves are nursing measures. And so the thinking is that to get nurses to be able to do the research and advance that care with baccalaureate, not necessarily to get research, but to move those systems together, the baccalaureate is needed. Now, the other thing about the baccalaureate degree, and I know this from my experience, is that in contrast to associate degrees, it has a community-based experience, which goes to the comment before, that if you want nurses to be doing, I'm going to contradict myself, I know, but home care, the curricula for associate degree doesn't have as much on community and based care. That said, I've met nurses from the Indian Health Service, and I listen to their stories, and I don't have words for how amazed I am that they're the backbone of that care without necessarily having the advanced degrees. So I said I would contradict myself, and I did, because the caveat that the evidence can be debunked and is not always perfect. So I want to emphasize that, okay, and that anybody can read these outcomes. I always say this, you can look at the same demographics. And you and I can all look at the same demographics or some kind of data, and I'll walk away with one conclusion, and you can walk away with another conclusion, but we're looking at the same data. So we just have to be careful about that. So I thank you very much for your comment. And to embellish on that, I'm proud to say that one of the fellows that we're bringing in this year is from northern New Mexico, is Navajo, and has great skill in just the kind of community-based in-home service that you're talking about. And I'm really happy about that because everywhere the data show that aging in place is so much better than going to a skilled nursing facility, and in terms of keeping people vibrant and alive in their homes. So thank you very much for reminding us of that. Long answer, but does it help you at all in my answer? Thank you. Thank you for the question.
Thank you, Sally. Also a nurse and have my bachelor's in nursing, and I just want to say that having a bachelor's has really opened the door for opportunity and really encouraging my tribal members and those interested in nursing to go on and get their 4-year and not stop at a 2-year, because it really does open the gates for you in terms of being able to manage, having positions that allow you to use the knowledge that you've gained in a 4-year program. And I never liked hospitals, so I'm not a hospital nurse for a good reason, but I think that's what helps having a 4-year degree, is being able to be out in the community and being able to use those skills to manage programs. But I wanted to make a comment on policy, because I think policy really depends on awareness and media, and a policy won't be effective unless you have the reinforcement and enforcement from somebody. So when we talk about developing policies that create healthy communities, I think what really helps is having the leadership support to enforce the policy that's being developed. And when we talk about chronic diseases, in preventing diabetes, reducing overweight and obesity, those chronic diseases are related to risk factors that are behavioral. So it has a lot to do with how you eat and physical activity opportunities. When we talk about tribal communities, I think we're at a good place. Having the CDC grant and trying to push policy in 2 years has helped me learn a lot. And we were, being compared to cities and counties. Well, cities and counties have streets, they have sidewalks, and a lot of policy that they were pushing were safe routes to school, putting signage up so that people are aware of walkers and bikers and runners. When we went there, we were like, okay, we don't have sidewalks, and we have only one main highway that goes through our community. So when you talk about policy on a tribal level, you have to really open your eyes and look at your community, and that's what's really helpful with community assessments, mapping out your resources. And so I struggle with policy at a tribal level because we're not like states, we're not like counties, we're not like cities. And so when you look at your tribal policies, the only place I found effective putting in policy was at the school level, because you can put in policies that help create an environment for healthy schools for the kids. But other than that, trying to create a community policy around obesity prevention, diabetes prevention, it was nearly impossible, because policy is sort of foreign to tribal leadership in a way. The way our governments are structured, there is no community policy. There's tribal ordinances and tribal resolutions, but if you don't have the leadership support or enforcement to back up those things, then it's sort of just a paper on the table. And so I guess my question is, how do we implement policies that will, one, be effective, and two, really prevent the diseases that create the health disparities, such as diabetes, obesity, cancer?
Let me try to answer your question. It's a wonderful question, a follow-up to some presentation. When people talk about policy, people often think about, how do we make people do what we think ought to be done? And so immediately people think of the negative, enforcement. Let's do something to punish them if they don't follow the rule. But, most public policy from any governance structure, including tribal communities, relies on voluntary participation and voluntary acts. Take, for example, when the federal government changed the speed limit on the freeway from what used to be open 80, 85 miles an hour, and they reduced it down to 65. Most of the time, you won't find a highway patrolman enforcing the law. It's mostly left to drivers and to the public to voluntarily follow that rule. Of course, there is some enforcement. Some of us have been stopped by the highway patrol from time to time because we were going a little faster than the 65 miles per hour. But by and large, it's a voluntary. And most public policies rely on that voluntary nature of communities to follow the guidelines or the approaches or the rules or the commitments that have been made in the community. Which is why in my talk I was trying to stress the importance of having a participatory process in place in which those kinds of obesity ideas can be put in place, where there's community buy-in to the idea. And even in tribal communities where you say there are no policy, there is a policy. It isn't necessarily a written one. In many communities, there are no written policies. But there is a policy in the form of a social norm. And that social norm has to be agreed to by that society or that community. So just in summary, there are three ways in which policies get put in place and get affected. The first is voluntary, that is, voluntary actions on the part of the community that buys in. The second is the need for enforcement. Sometimes it means police, it means inspections, it means all a variety of things that we know as potentially negative, stopping particular kinds of activities. But the third is one that often gets forgotten about, and that is incentives. Sometimes we need to provide incentives for people to actually act and behave in their own behalf, for their own good and for the good of their own societies. So there are those three kinds of mechanisms at play in which you implement a policy, or that you make sure that policy actually occurs.
I just want to quickly also add to what Dr. Valdez has said, and really just ask you to broaden your concept and what you think of as policy. Particularly in a tribal community, there's a lot of opportunity that you have within your community that most people don't think of as policy. When we talk and we hear the word policy, we think it's something that's in a book. Like Dr. Valdez said, that it's something that's an ordinance or a rule with damage or with punishment associated with it. But there's a lot of opportunity in the things that you do in your community. If you participate in your community dances or any of the things that you do, there's a lot of opportunities that are there for you that people can change that don't really recognize as being health policy. So two examples that I'll give you from Zia is, every year we have a curing ceremony that we start off the year right. We cleanse ourselves, we cleanse the village and everything. And for preparation up to that day, a lot of ladies get together and they prepare a lot of food for the tribal officials and as well as for the medicine men and everybody taking part in the whole ceremony. And my aunt, Jean, who's a CHR, 5 Sandoval, you probably know her, Jean Pino, she was part of the cooking crew. But what she decided to do, knowing that feeding people with lard or using lard in the beans and that was not exactly healthy, she chose to use canola oil and other healthy food alternatives in the cooking of that food. Didn't really tell anybody, and nobody really noticed that there was a difference in the food, but yet she was feeding them healthier food. And so that was a change in health policy that really benefited the community members that maybe people really wouldn't think of normally as a health policy, and a change in that. And so from there, they've kind of changed how they've done that. The second example is, this was also not even thought of as being a health policy, was the purchasing of cigarettes by our tribal council. In our council meetings and in other community gatherings, oftentimes it was part of our budget line item to purchase cigarettes. to give to the men to utilize and everything. But we realized we were spending a whole lot of money on the purchase of that cigarettes every year, and every year it seemed to be going up because the cost of cigarettes were going up and all that other stuff. So we just cut out that budget line item out of the tribal budget. So not only did we save ourselves money, but we also were not a source of cigarettes for our community members. And so people that couldn't afford it had to find it some other way, and we didn't contribute to the smoking of our community members or to the males in our community members. So for me, again, that's another example of a health policy that really wouldn't ordinarily be considered a health policy decision or matter. So there's a lot of ways that you can think about it, a lot of opportunities that you can do and use that may not be written down, but are changes that you can suggest or make just by your social interactions with people in your community that can be health policy.